of folks at it. So today we're going to talk a little bit about the power of partnerships. And these are our learning objectives, is to really understand the significance of collaborative partner interventions in addressing substance misuse in youth and adult populations. Also looking at ways to identify multi-system response strategies to address emerging drug trends and high system utilizers in a community. And then also looking at recognizing the importance of creating multiple pathways and wraparound services for our individuals and families suffering substance use, co-occurring disorders, and addictive behaviors. And so drilling down to the weeds a little bit of my board is really looking at marrying public policy, public health, and public safety. So this is who provides me oversight. So I work for directly the three fiscal courts, the three most northern fiscal courts of Northern Kentucky. So that's Boone, Campbell, and Kenton counties. So I work closely with the judge executives. And then rounding out my boards for public safety is working with the Northern Kentucky Drug Strike Force, and then our public health with the Northern Kentucky Health Department. But then also having St. Elizabeth Healthcare on our board has been a game changer for our region, looking at marrying that public and private health perspective and bringing in providers. And then working with legislators. Our legislative liaison is Representative Kimberly Mosier, who was my predecessor, who had this role for several years before I stepped in. And then just a note, I get a lot of questions about how are we funded, where am I placed? And so my fiduciary agent is at the Northern Kentucky Area Development District. So that is a special government entity that works with local governments. And so that's where I'm housed, and they provide me, of course, office space, HR support, a finance department, and things like that. And so then I always get the funding question. So my office is split up into two different areas. So what we call the office, which is myself and an assistant director, and we look at really policy and strategic initiatives. And then the other half is our addiction helpline that we oversee. So for the office part, the fiscal courts take on that fiduciary responsibility. And then the helpline is split halfway between my three fiscal courts and St. Elizabeth Healthcare. So I am a team of 7. And right now we have 2 open positions for our care coordinators for helplines. So I have myself, my assistant director. We have a helpline program manager who has a credential to help with assessments. And then we have our care coordinator, Josina, who's been with us for a long time. And then we're actually in the process of hiring 2 more folks, if anyone is interested in looking more into that or working in Northern Kentucky. So this is our mission statement. The Northern Kentucky Office of Drug Control Policy assists with the development of substance misuse policy initiatives, coordinates regional efforts at the direction of the board, and provides advisory services to the fiscal courts of Boone, Campbell, and Kenton counties. So what that really means is I oversee strategic initiatives. We just wrapped up our 3-year plan, which I'll talk a little bit more in just a little bit, but then also looking at policy and then working with the fiscal courts on their county department, which may be working with the county attorney. We advise on the county detention centers and programming. We look at deflection, dismissal, and diversion programs, working with the different court programs in our counties, and being able to provide a multi-system perspective. So again, our 3 kind of areas that we look at are those regional strategic initiatives, state, local, and organizational policy, and then our addiction helpline. And so for regional planning, we just wrapped up in December our 3-year plan. And so they were broken up between prevention, harm reduction, treatment, and recovery. The plan was devised with about a year And we had hundreds of stakeholders input, lots of organizations in this work. As we know that our work is across many systems, and we know that organizations working with our families are probably working with them as well in another capacity. And so really pulling those community stakeholders together and looking at the gaps of services. So we did surveys and focus groups and workshops, lots of flip charts and Post-its, and some really robust discussion. And so we were able to come up with our strategic plan with our 4 main goals. And then looking at our community overarching themes. It was important that we were looking at a no wrong door into treatment and recovery. Meaning that at any point, someone could walk into an organization for reentry services, job services. Maybe they're visiting our local community action commission offices or one of our nonprofits, such as Brighton Center or childcare facilities, and wanted folks to know that at any point that they entered the system is that they could reach resources for treatment and recovery. Because we know recovery takes many forms and many paths. We're really looking at evidence-based or theory-informed practices, looking for that innovation there, looking at increasing that continuity of care, breaking down those silos, and really those high system utilizers that may go to the emergency department, they may be in our local detention centers, and police may be called to their house or EMS, and those folks that for whatever reason just can't seem to get onto the right path or have so many barriers that they're unable. And really looking at some really sick individuals that we wanted to make sure they had access to healthcare. Decreasing the stigma. I firmly believe that stigma is our biggest barrier to treatment in Northern Kentucky. Want to build capacity by promoting our already robust social infrastructure. In Northern Kentucky, we are fortunate to be resource rich. We do have gaps in our system. We do not have everything figured out, but I know talking to many communities around the state and nation is that we do have quite a bit of resources and making sure that folks know about what we have. Want to engage and support our law enforcement and judicial system. That was a big part of this 3-year plan, is looking at that next phase of reentry. And then allowing for all stakeholders to have a voice, and then aligning that work across community systems and sectors. But we also want to celebrate our successes, whether that be individual, family, or partners. And that's something that we still try to put some focus on too, because those of us who get into the weeds with this know that it's hard to see the light at the end of the tunnel when you keep just putting one foot in front of the other, trying to help our folks. We want to acknowledge and address the childhood adversity, also break down treatment and recovery barriers, and advocate for those policy changes at all levels. And then most importantly, meet people where they are. I firmly believe that people are the experts in their own lives. Everyone has inherent worth and dignity, and they know their situation better than anyone else. And oftentimes that's hard in this work, as we want to get folks onto a path that we think might help them be successful and self-sufficient and address those health inequalities and disparities. But at the end of the day, it has to be the decision of the individual seeking recovery. So it's a little bit of our regional planning process. And so one thing that we did was really look at hub models. And so this work for Northern Kentucky kind of coming together and aligning, looking at system integration, started in 2012 with the Heroin Task Force. I didn't come to the Heroin Task Force until 2017. So there was always already lots of good work happening before I came into the picture. And as our previous health district director, Lynn Sadler, would say, this was really the first time that systems came together, that police were at the table at the same time as public health. And they were able to start talking about what they were seeing. How could we start addressing this in different ways? What were the drug trends? So as we continue to increase our response strategies, the natural progression was looking at hubs. And so we've done a great job of working for treatment and really enhancing that wrong door. There's still some work to be done there, and that'll be the next focus in the next couple years of our strategic initiatives. But we have a harm reduction hub. We're looking at regional naloxone and Narcan policies. We are fortunate in the state of Kentucky that our state is able to provide Narcan to many organizations such as mine to go out and train employers and nonprofits and community members. We have additional resources for law enforcement. We are still working on getting EMS Narcan, which is coming close to be able to provide our local EMS agencies with Narcan. We're looking at regional data. If everyone could mute, that would be super helpful. Thank you. And so also looking at for prevention. In Northern Kentucky, in our 3 counties, we have, in the top 3 counties, we have close to 6 prevention coalitions in different areas. And knowing that each community has some different areas to focus on. And really that is the aim of a prevention coalition, is to be on that local level and to address those local needs. But looking at how can we have regional strategies, that might be looking at our adverse childhood experiences, making sure that we get the education and awareness out there about resources at earlier ages and to school and different youth serving organizations. And then the most exciting thing that I am pretty excited about in our last strategic plan was creating our reentry hub. So we are fortunate in Northern Kentucky to have an organization called the Life Learning Center. It is in Covington. And actually that's where I'm working out of today. I have 2 offices, one in Florence for our Northern Kentucky Area Development District. And then I have one in Covington, where I spend half the week in Covington at the Life Learning Center. And here at the Life Learning Center, folks are released from our detention centers and come straight here. And they're able to get food right away. There is those emergency resources for clothes and hygiene if they are coming from a detention center. They have a curriculum here for folks to get on the right path, as it's really reentry and workforce development. But they work on that kind of stabilization piece first. And I can tell you from being in the building, there's many folks that come in straight from jail or come from different places. And the first thing they say is, you know what, I've got to get to treatment today. I need to get to our behavioral health hospital. I need to go to residential. And then they can make that connection right then and get in same day. So again, enhancing that no wrong door, coming into a reentry organization, but knowing that there's a direct connection to treatment. And there's oftentimes that folks come into this building for different things, start getting screeners and questionnaires about what their needs are. And then we can do over the phone assessments to see where they might have success with treatment. And if they're willing, oftentimes they can get a same day appointment as well. So that's looking at our hub models and where we'll be expanding in the next 2 to 3 years. And so I want to talk a little bit more about that data, is really that collective impact. So in my office, we do data dashboards, and there's a link to our website where our data dashboards, and we track our non-fatal overdoses. We get them through our county dispatch, and we're able to provide outreach if necessary, but also to be able to look at trends. And in some of those trends, we can see, you know, if there's a spike at our hotels or our school grounds. So then I have staff that can go out there and meet with folks and just kind of set up a table and hand out information, link folks to treatment same day, or we can work with those organizations' leadership and advocate to get Narcan into their businesses or school system. And that has been very effective. And then also really just looking at that data to make those data informed decisions about where will we spend our efforts, making sure that we're not duplicating resources, and making the most of those resources and leveraging them. So some of the things we track is, of course, our addiction helpline calls, which I'll talk a little bit more in the data in a bit. Fatal, it's actually be fatal and non-fatal overdose. In one of my counties, I get all social calls, so I'm able to track trends for domestic violence, emotional crisis, and things like that. And so we're working with the other counties to track that, because I firmly believe that substance use and mental health issues go hand in hand many times. We are able to track our syringe access exchange programs and participants. That is another area of my staff that does outreach. So I'm able to provide a staff member to each one of our syringe access exchange programs. They happen on Tuesday, Wednesday, and Thursdays in Northern Kentucky. And I have a staff member there that's able to spend time with folks, look at their resources, link them to treatment same day if they wish, but really to build those relationships. We hear from our syringe access exchange program participants that connecting with the health department in this way is the first time that they have felt that their life has mattered, that someone cared about their health decisions. So really making those first great decisions towards better health. And we know that our folks sometimes will come back 5, 10, 15 times before they're ready. And some folks are never ready, but we're able to make those relationships, call them by their first name, ask them how they are. How's that dog of yours? If you're ready for treatment, we can find a place for your dog for 28 days if you'd like. So being able to really have those conversations and let them drive their own recovery and treatment journey. We are also fortunate that we have an Uber Health program. We have written some grants and have received funding, but also I get funding from St. Elizabeth Healthcare and my fiscal courts for Uber Health. We know it's a huge gap in the system. This program does not work everywhere. One thing we have found in our more rural counties is that we can offer it, but we can't always get a driver to pick up. So we know this strategy does not always work in all areas. But for us in a more urban setting, it works for our top 3 counties most of the time. And oftentimes when folks are released from jail, we can pick them up from jail, drop them up the Life Learning Center to get a few of their necessities, kind of start getting their appointments in order. And then we might take them to our community-based mental health provider. They might also see their probation and parole officer that day, and then back to the Life Learning Center to figure out their next steps and get a bus pass to move through the next couple weeks. And it's not uncommon for us to do all of those appointments in one day, because we know the bus systems just always don't line up for appointments. And our folks who are seeing lots of people in lots of systems need to be able to do those quickly as they're breaking down those barriers. So a little bit about our data dashboard and how that Uber Health works. So this is just our non-fatal overdoses that come through dispatch for Boone, Campbell, and Kenton. I will be expanding to all 8 counties because I am placed at the Area Development District, and that is an 8-county serving organization. So as part of the collaboration and partnership there and local government, I'll be able to do that pretty easily this year. But this is looking at these that come through dispatch. And there are a few DOAs, dead on arrival, unfortunately, that come through dispatch. So not all of these are non-fatal, but just wanted to point that out, that if it is called through dispatch, it is tracked here. So these are our numbers that come through dispatch only. And so one of the needs, I'd like to show this slide because we have learned that this is not all encompassing of our data. We have data that's going through EMS. There's also data that goes through our emergency department. So this served really well for a while, but looking at that regional kind of data hub, we will be using OD Map. If you're not familiar with OD Map, I urge you to look into it. I know in the state of Kentucky, they were able to expand through the CDC, but this is OD Map is an initiative out of Baltimore HIDA, and they offer this free to many communities. And so you're able to go on and look at that information. And so where we were looking at this data is we knew it was actually quite skewed. And so now what we see through OD Map is that at each of our 3 counties, we are seeing each day about 3 non-fatal overdoses. So we're seeing 9 just about every day in Northern Kentucky right now. So a little bit about our charts that we are expanding on, and then also tracking fatalities across the region, the state, and nationally. So I know preliminary numbers just came out for Kentucky just this week. I am cautiously optimistic to say that Northern Kentucky has had a dramatic decrease in fatal overdoses. They are preliminary, so we're waiting on final numbers. Any decrease is great news for us, but we're always looking broader to see, is this our efforts of pushing out Narcan? Does this have to do with a switch in an increase in stimulants? Are folks, we're losing less folks because of expansion of treatment, where I think all of these things could be included, but it's nice to kind of have a quick data snapshot. And so as we get those numbers finalized, this will be updated as well. And so looking at that data dashboard, and what we want to do is really looking at how do we include more information about our drug trends and how does that affect us. And so in Northern Kentucky, what we are seeing is still an overwhelming amount of fentanyl and fentanyl analogs. We have started to see carfentanil back in the area. Over the last year, we have a significant increase in methamphetamines and illicit pressed pills. And with all of those are all still laced with fentanyl as well. By the time I have made this, there has been an increase of cocaine, and I am hearing that from our HIDA and our drug strike force that in the coming year, cocaine is going to be increased as the cartels are spending more time diversifying their market. The Mexican government is looking at, shutting down the fentanyl manufacturers. They have not been burning cocoa fields. So cocaine will make a comeback as we're going to see an increase as they are planting and getting ready to harvest. So just wanted to put that out there. We also see the vaping devices. And then something that I had to add for this presentation was heroin. We had not seen heroin in Northern Kentucky in probably 4 or 5 years. It has been straight fentanyl, but we are starting to see pure heroin again, which has been new for us. We've not, straight from poppies. It has to be harvested. It's coming in, and that has been a reemergence because we have just not seen that in quite a bit. We are seeing xylazine. This is a large animal tranquilizer. And we are seeing it sometimes mixed with fentanyl. And the xylazine, I'm not sure if folks are aware of that, but they are able to, they have skin wounds that kind of pop up. Just checking the chat to see if there's any questions. And if anybody has a question, please feel free to stop me. I think it adds to the presentation, and then we won't lose it as we go forward. And so whatever works best for folks, feel free to unmute and interrupt me, raise a hand, do your questions, whatever works best. And then, of course, I put alcohol on this list because when I look at my emergency department data, my inpatient hospitalizations, and my dispatch records, alcohol is still a very large problem in our community, and it seems to be growing each year. I did put the one pill can kill icon on there is with a link. This is from the DEA. This is a national campaign. We're trying to also look at different ways to push out information without recreating the wheel, to get information out there that some of these folks are college kids, or, I know how folks get healthcare is they get it from a friend. They can't get into the doctor, not sure where to start with mental health. And, I know folks share Xanax and different things. in really getting out the information that you just can't do that. You don't know where things are coming from, and one pill can kill, and we've seen it. So really getting that awareness out there. Okay, so one of the multi-system response strategies that I am most excited about is the deflection and pre-arrest diversion. So this is in the field of police social workers, quick response teams, post-overdose outreach. It's also called LEAD, law enforcement assisted diversion, lots of different terms for this. And so really looking at to try to catch folks before they enter or re-enter the criminal justice system. So just some of the work that we've done with Northern Kentucky in my office is able to secure money for a care coordination system for all of our pre-arrest diversion partners that are working in the different counties. One thing I love about Northern Kentucky is that we have a very diverse communities within our 3 counties. We're not all urban. Each one of our counties has a more urban and rural feel. And we know that what happens in Alexandria is very different than what happens in Newport. What happens in Independence is very different than Covington. And the same of what's happening in Boone County. As you're closer to Florence and get closer to what's happening there is to the more southern parts of the county. And so in my 3 counties, I have 37 cities, which comes to close to 37 police departments and 37 fire departments. Those numbers don't quite add up, but you get the picture. And so we got lots of different entities and organizations and local government arms working to do this. And so making sure that communities can address their issues the way they know best. Again, they're the experts in their own community, and we're here to add technical assistance, support, add capacity to what they're doing. And so some of what I can do to those folks in Alexandria who has a police social worker, or Kenton County who has a QRT officer, or one of our jails that has outreach, our nonprofits that have a community outreach team partnering with the police department, is I can provide a software system and they can track their data and do care coordination. And so I'm also able to do training and pay for training, knowing that it's hard to allot training for one person in an organization when all of our systems are over-resourced and underfunded most of the times. So I'm able to provide training and invite folks. I'm able to help them with grants, able to present and do some anti-stigma work with our officers. One thing I've learned from working with first responders is that they'll say to me, I've never seen anyone in recovery. We are just going back to the same places. And that helped me really understand some of the attitudes that we were getting from first responders and why law enforcement teams were resistant to have Narcan, where some of our county departments just didn't understand why they would need Narcan. But the more we get out there, the more that we talk about recovery, we talk about the importance of health in our community, addressing these health issues. We are making movement. You know, I'm getting correspondence just in the last couple of days of, hey, I think our Parks Department might want to have Narcan. From tracking our data on dispatch and overdoses, been able to go to the leaders of school systems and say, hey, you're having an increase on school grounds. Do you know this? Can I come in and talk to you about Narcan? Can I talk to you about resources? And they're allowing us to open the doors as they're seeing this from every level. I don't know that there's anyone in our state, definitely not in our region, that does not deal with substance use disorder and addiction on some level, whether directly or indirectly. Our office was able to develop a QRT toolkit, is what we call it. And it's really just some SOPs about what we've learned about intake, best practices, how to use peer supports in this effort, follow up. We've knocked on hundreds of doors. after overdoses, talked to lots of families, put out lots of information, and have learned a great deal. So if anyone is interested in learning more about police social working, quick response teams, pre-arrest diversion, please don't hesitate to reach out. And there's some wonderful national organizations that help with this. There is PTAC through Health and Justice and Task that has free calls every week and offers a lot of support. There is QRT National. And then there's also PARI, PAARI, which is the Police Addiction Assisted Recovery Initiative. And if you Google any of those or reach out, I can give you more information, but they offer free calls, free support, and lots of great information if you're interested in learning more or bringing this back to your law enforcement and government leaders. And so one of the things that I like to say all the time is healthcare, not jail. And the more I say it, the more it catches on. And so making sure that our folks know that we are pushing for folks to get health access. We cannot arrest our way out of this. We cannot incarcerate our way out of this issue. And it doesn't serve the individual or family best that way. We know that in our local detention centers is that 85 to 90% of the folks in there are there because of a mental health diagnosis or a mental health issue that has never been diagnosed or a substance use disorder. And so wanting to get to the root of that issue. So I do a lot of this work because I think ethically it's what we should do. Everyone deserves health care. Everyone deserves an opportunity to have the best health possible. But I also am tasked by the fiscal courts is to look at county budgets. And so it makes most financial sense if you take everything else away from it to invest in these families, in these individuals, offer them the health care so that they can work on whatever issues that they feel that they need to. And if we can help nudge them that way, that is fantastic. But to put someone in a lockdown facility for $25 a day on the county budget for 30, 60, 90 days is just not financially effective. With that, a lot of the folks that come in need different kind of healthcare. They're not seeing preventative care. They're not seeing primary care providers, and we want to be able to make that connection as well. And then looking at these folks that may need lots of care, that responsibility also falls on the county to give folks that care. So we want to be able to move those folks to the healthcare system to get the help that they really need. One of the things Kentucky is doing on a policy level is looking at in our Medicaid reimbursement policies is the 1115 waiver. And so we're advocating very, very heavily that would allow folks to utilize their Medicaid while incarcerated, whether it be a week, 2 weeks, 90 days, 30 days, is that we can really start that treatment and reentry process from jail. And then it doesn't fall on the county's budget because there's just not enough money to bring in providers. And then we have providers that aren't able to be financially sustainable in that way either. And so they would be able to access their insurance while incarcerated. And so we are waiting diligently every day for a response on that. Right now, it's just looking at substance use disorder treatment. And then I'm hoping to advocate to expand that to mental health disorders as well. But these are really just kind of our approach looking at that, moving folks from the criminal justice system to healthcare, deflect more individuals to community-based services, enhance the quality of life for our justice involved individuals and family, remove those barriers, break down that stigma, collaborate more, strengthen our services, and advocate for those public policy improvements. And looking at how do we improve community relationships between providers, sectors, individuals, families, community members. And so when I talk about diversion and deflection, they're very, very similar, as well as dismissal. So for diversion, we are diverting away. So that usually means there's some kind of run-in with law enforcement. It could be before or after. And then deflection is whether they're just now entering or that overdose that we might see on the overdose report is we want to deflect them. And so that really means just taking kind of a back door and deflecting them to community services, finding out that some of our folks are ready for intensive outpatient, but they really need housing. So we're going to stabilize them, deflect them to those community resources, and then link them to care. And then dismissal is usually working with probation and parole in the courts, and seeing if we can lessen those charges. And so looking at our helpline, we're not quite operating 24/7 because our scheduling always is dictated by volume, call volume. And right now we're just not having the call volume. We seem to be operate 24/7 right around Thanksgiving, Christmas, and New Year's. That's when we see a big increase. Someone in the recent years has told me about the February fail. I don't know if this is scientific, but someone had given me that term, is that as we see January folks kind of enter for New Year's after seeing their family, we have a lull in calls. But as folks get to that second month in February, there may have been a reoccurrence. And at the end of the month, we have seen an uptick, a tick each year in February. And then we go back down again in March and April. And so our call volume will be a little lower, probably until about mid-June, until it starts getting really, really hot. As it gets really, really hot and sticky, folks are ready to kind of get out of the elements. And we see more calls of folks getting out of the elements in the warmer months than the colder, which before I did this, I would have never, ever imagined that to be the case. But we, in Kentucky, we have Casey's Law, and that is a involuntary treatment option to petition the courts. We do the post-overdose outreach. We have resources listed on our website, and we do not ask anyone if they have an addiction. If they call and ask for housing or a food pantry, we give it to them, whatever they may need. We do a lot of community outreach and help get folks set up for referrals, and take a lot of frequently asked questions about different services that we have in our community. And so I'm not going to go through all these meetings, but our small but mighty staff, we're a little bit smaller than usual right now, but we attend lots of weekly and monthly community meetings. And again, Northern Kentucky is very lucky that we have lots of great resources, lots of great work happening across all levels. And so this is just a snapshot of some of the weekly and monthly meetings that myself or staff attend. These are some of our outcomes, just to show you a few things that we are tracking, which I won't go into a lot of details. But looking at that Uber Health, looking at the dispatch, Narcan, you know, how many syringe access exchange programs are we connecting to resources? What's our follow-up look like? So just some data. And recently I just ran my numbers. We hit our 5-year anniversary in March for our helpline. And within the 5 years, we've taken over 4,000 calls. That does not include follow-up calls or what we call interactions. A lot of times our folks call and they need quite a bit of information of what treatment might be on a bus line, what are the different options for IOP. And so those interactions mean is that my staff has to call quite a few IOP organizations to get the schedules and get the options depending on insurance. And so we're able to do that really detailed kind of hand-holding, is that we know folks are exhausted with. And then on a personal level, I have a parent that deals with substance use disorder. And when you're in that crisis, it's hard to function at the full level of which you know you can. When I'm advising a person to do this, it goes a lot easier. I can move very quickly. But when it comes to your own family, even someone like myself who knows all of the resources in Northern Kentucky, sometimes you just need a little bit of help. So there's some outcomes, or I'm sorry, some different, outcomes of our helpline. And so looking at policy, this is what we're doing on the policy level. Kentucky just passed a Senate Bill 47 on medical marijuana. That's going to be very interesting for us to roll out. That's going to roll out in 2025. And I have a 150-page bill that I'm still getting through. So lots of information to come about that. We have Senate Bill 90, which is our dismissal and diversion pilot. This is 11 counties in Kentucky, and Kenton County is one, working with the Life Learning Center. It's another reason why I'm down here in the building, but really looking at one of those multidisciplinary tactics that we have. And so out of this building, working with our Commonwealth's attorney, our prosecuting attorneys, probation and parole, is a group that we call MRRT. It is a multidisciplinary reentry and recovery team. And they're actually meeting right now. They meet every Friday at 10:30, and all the providers get there. All our treatment providers, our community-based mental health providers, probation and parole is there. It's really a multi-system hub meeting. And they have a list of participants that were either court ordered or follow up, or did not show up probation and parole, or they've given an option for treatment instead of jail. And so this group meets to break down those barriers and say, okay, well, why didn't this individual show up at our community mental-based health program? And then it comes to find out, well, the appointment was set for this date, but that coincided with probation and parole, but probation and parole could not release them to go to treatment. And sometimes it's just administrative or paperwork. And so they can work those details out there. And then somebody who is working on that team for that individual will say, okay, well, I'll reach out to this person and let them know, are we all in agreement? So I'd love to talk more about MRRT. If anyone would like to talk about that, we're adding Campbell County, looking at adding Boone County to that as well. So for those justice involved folks that we really want to move them to healthcare and away from criminal justice. House Bill 7 of 2022 was Recovery Ready Communities. We are in the process of submitting a regional application to our state. And so this is a blueprint of what a recovery ready community should look like. We are going to put that application in and have a review in just a couple weeks. And so we're excited and pretty optimistic that we will have that designation. So we've been following that. House Bill 248 this year just passed about recovery housing regulations. And so there's going to be 4 different options for credentializing our recovery housing. And preempting that was going to happen, we were able to kick off a recovery housing consortium out of our reentry council. And so that consortium is looking at engaging recovery housing individuals, folks that run those houses. We have some great recovery housing in Northern Kentucky, and we have some not so great housing options for folks in recovery that sell themselves as recovery housing. And so being able to work with local governments of how to get some of our not so great players out of the picture. How do we help those get credentialized? And then making sure that all of these houses have access to Narcan, transformational job list. We have over 200 employer partners that work with folks in recovery and making sure that folks in those houses know about these things. We also had House Bill 353, which allowed for fentanyl testing strips. They had to change the statute, so we're able to roll that out in our harm reduction programs and syringe access programs, already handing them out, and they've been very popular. We are seeing that is changing behaviors, and I'm happy to share any of that data and information there. Kentucky finished their opioid abatement funding settlements at the local and state level. So I'm working directly with our local counties to best use those funds and advise. And then also we will be putting in an application to the state looking at crisis intervention and rapid reentry team, working with our emergency departments and our treatment providers, our mental health hospital, my helpline, and our health department and life learning center is our reentry hub. So we're very excited, optimistic for that as well. And then again, we're looking at those regional naloxone Narcan policies. We are fortunate to have Narcan resources. And so figuring out who's tracking the data, who's best. One, we don't want to step on each other's toes. We don't want to create more work for others. We want to make sure that we're all kind of moving in the right direction, and anybody who needs it has it. And then we can also track the data. And the same with our diversion, deflection, and dismissal programs. So again, looking at that public health and public safety systems change, more about pre-arrest diversion and deflection. Pre-arrest diversion is that front door, partnering with law enforcement, and deflection, partnering with community services. And we know that good public policy can dramatically improve public health and public safety outcomes when maximizing resources and leveraging existing funding. So we want to do this for many, many reasons. Why is it important to collaborate? Again, what my office is able to do is pull together local government, public safety from many different levels, working with county, police departments and sheriff departments. We are drug strike force. And then Northern Kentucky is actually part of Hamilton County's HIDA, the way we are positioned. So working with HIDA in that way. Of course, our public health system and our hospital system and public policy. So pulling all these pieces together is important for us to make sure that one, all the leaderships are talking. We are investing funding in making sure we are maximizing those resources. Again, it's the right thing to do. It saves lives and it reduces recidivism, infectious disease, overdoses, and death rates. It's very important to me that we meet people where they are. As someone who's grown up with family members who are mentally ill or with substance use disorders, it's important that the options for care are person-centered and patient-directed to best fit that individual and family. We also need to strengthen the social infrastructure. The folks that do wraparound services, reentry services, childcare services, we want them to do the best that they can do because we know someone entering crisis treatment, eventually they're going to get down the road where, you know, they might need a job, and to have that job, they're going to need transportation, housing, and childcare. We need to support our nonprofits to do this great work. We know that we're all in it together, and collaboration is key. This also addresses multi-generational trauma, adverse childhood experiences, and the social determinants of health that contribute to SUD and mental health issues. Again, we cannot talk about treatment and recovery if we're not going to talk about access to healthcare, transportation, housing, incomes, jobs, opportunities, multi-generational incarceration. These are all part of our picture that we must solve. And then at the end of the day, I am a county employee in looking at easing that taxpayer and multi-system burden for our system, for the folks that work in those systems. And we want to reduce the service duplications. And again, utilize those existing resources. That is all that I have for you today. I'm happy to take questions or to talk more about anything I've talked about today.
Thank you, Amanda. I think Jane had a question in the Q&A section. If you could see that.
Sure. It says, you've mentioned that some treatment and recovery centers are not effective and some are in Kentucky, and you'd like to see those non-effective go away. Can you expand on what makes a facility effective and what doesn't? Yes, of course. So in this particular instance, I'm talking more about recovery housing. And so really looking at that NARS, National Alliance for Recovery Residences framework, making sure that there's a different, folks that are attempting to provide levels of care are meeting those standards of care, making sure that it's safe for folks. If it is an organization that says that they're going to take folks on MOUD, that they continue to do that and they're consistent. And if they're going to take MOUD, they take all MOUD forms. If they allow for that, then, they need to allow for methadone and buprenorphine or Vivitrol or Suboxone or Sublocade or whatever medication it may be, as we know those are evidence-based. Again, we're not saying that every house needs to take MOUD, but if they do, they should not discriminate on those medications. And we also know that we have houses here that operate pretty frankly as trap houses. They are dangerous. People are using, they're predatory. There's no house managers. And so we need an avenue to shut some of those places down, that they are safe places, that folks are very vulnerable after they leave treatment, that they can stay on the path that they want to stay on that health journey. But then also some of our folks that if they're leaving jail or were going to an IOP, or maybe they did a jail substance abuse program, is that they're leaving and not going to a recovery housing where it's going to be predatory for them, because we know folks leaving our local jails are the most vulnerable for overdose and death. So that's really kind of on the recovery side. Northern Kentucky is very fortunate to have treatment. We worked on expanding that in the last 4 years. 4 years ago, we did not have residential treatment. We did not have, I could rattle off 10 IOP options that we have that we didn't have. And we want to be able to keep given folks those opportunities to seek treatment. Well, I think there might be another question. Does brokering still exist? I probably need more information on what you're talking about, Jane, before I answer that question. I think I have a good idea, but if you could give a little bit more information, I would appreciate it. Okay, so Jane's asking more, are patients recruited with insurance? Honestly, I don't see that. I will preface that by saying that I am not a clinician, I am not a provider. But as part of our No Wrong Door to treatment and recovery, we have a system for folks who don't have insurance to get into our system. Our Community Action Commission is tasked with being our Medicaid assisters. So we have Medicaid assisters in every county, but then also adding capacity is that all of our treatment providers, if somebody walks in with no insurance, we can usually get them signed up same day. We find that Medicaid pays out often more than private providers. So there isn't really a preference there. It's not very often that folks are turned away without insurance. And if they have private insurance or copay or Medicare, that's when we get a little kind of stuck in trying to find them the best options where they don't have to pay out of pocket. And we often have times where we work with our Medicaid assisters and treatment providers where they might even drop their private insurance because they have a $3,500 deductible that just can't be met. And we're able to sign them up on Medicaid to get them treatment, if it's not same day, within 24 to 48 hours. Let's see, for recovery homes, Jane is adding, I don't see, Jane has put in the chat, brokering is a predatory practice, so patients can be charged unethically and even given drugs to justify the claims. I don't see that within our local treatment providers. I'm not saying it doesn't happen. If it is happening, we definitely want to know because I'm in a position where we can advocate for policy changes there. Within some of the non-regulated or not so great recovery housings, I would not be surprised that anything could happen of some of the horror stories I've heard, but of our reputable ones, our community partners, the ones that show up to meetings, we don't see that. And I think we're at a place in Northern Kentucky where we finally have gotten the word out about treatment, that we're trying to get as many people in as possible. And we often have folks that come in and out of our treatment. So we try to serve them as best as we can. Not saying it never happens, but it seems to be a lot less than maybe, 10 years ago or so, where we heard some of that happening. Thank you for the questions, Jane. Those are great.
Is there any other questions anyone has for Amanda? If that's all the questions, then I'll just say a few closing remarks. First, please complete the evaluation survey in the post-event email, and that'll be sent out in the next 24 hours. And the recording of this webinar will also be on the Prevention First website under our Training Hub tab. So thank you again, everyone, for attending and listening, and especially thank you, Amanda, for presenting. And that is really all. So have a great weekend, everyone, and bye.
Bye, thank you so much.
Bye.